Hi, welcome to this episode in our Conversations in Medical Education series. Today I'm talking to Treasure McGuire about how to learn to be a prescriber on your placement. Treasure is our Associate Professor of Pharmacology, clinical pharmacist, and has won multiple awards for her teaching. Thanks for joining us today, Treasure. Okay, well, why is it important to learn prescribing when you're on a rotation in medicine or surgery? Haven't you done such a good job of teaching it beforehand that it's all sorted?
I don't think so. Prescribing is something that you learn and practice and continue to practice throughout your professional life. And we can give the building blocks and give you opportunities to practice that through years 2, 3, 4, and 5. But it's not really until you get out in the real world and you have to do this day in, day out as a junior prescriber that hopefully those concepts will help prepare you, but it doesn't matter how good you think you are at this, you are at risk somewhere in your life journey as a prescriber to make a medication error, be it small or great, and that can have major consequences for you for the rest of your professional life. So treating this as important and treating prescribing as a communication where you need to be as transparent and as clear as possible is possibly the best message I can give any junior prescriber.
Thank you. I really like that introduction because it really clearly locates it in a quality and safety space. And with any of the choosing what you want to learn about, what you can learn about, focusing on things that are quality and safety issues make a lot of sense. So that works for me. Now, when it comes to what you learn as a prescriber, the what do you suggest that students focus on when they're, sitting in their medicine term, with an opportunity to see patients in real life? What do you suggest they focus on?
Okay, so think of this as part of your diagnostic workup so that you've got to decide, what medical condition or conditions you're dealing with, and then based on that condition, you may come up with an action plan. And in that action plan, you're looking at what else is going on in that patient's background, medical and pharmacological history, where even if the guidelines might say drug X is first choice, there might be something in their clinical background that makes drug X not suitable for them. They have liver impairment, renal impairment. There may be a better option, the second choice in the ranked order for that individual patient. And before we make the assumption that we have to treat the symptoms in front of us, could those symptoms be caused by something they're already taking? One of the biggest problems we see in the cascade of harm from medication and prescribing is where we treat the side effect of a current medication with yet another drug, and then the cascade continues. So first of all, rule out, could it be a drug-related cause? And then we look at the condition or the symptoms in front of us, thinking about what the guidelines say, and then applying the individual patient parameters to help us twig our choice. So it's really making a decision whether you put pen to paper or not, and being able to justify or stand behind your decision. Because when it comes to harm, you're put in the position of having to do that justification.
Now, one of the things that interests me is that our students are not the prescribers as such. Or they're practicing prescribing, but they're not the prescribers on the ward. But what you're talking about gives a role to them, which is really could be an advocate role, where being on the ward round and saying, do you think, is it possible that this itch is a side effect of a drug? What a great role for a student to have.
Exactly. Yeah. And they have a recency effect. Hopefully they can still remember their second and third year, pharmacology, clinical pharmacology, to go back to those first principles and raise the question. It doesn't have to be the cause, but you've started the team thinking about that option before they go on to make a prescribing decision.
The and I guess there are similar sorts of things with drug interactions in a way.
Exactly. So we know that as the patient goes on to receive multiple medicines, with each additional medicine, you increase the risk of a drug interaction, wanted or unwanted. We were just doing revision with our second year students, and one of the topics is gastroenterology, drugs in the liver, and a workshop on cytochrome P450 interactions. And thinking about the example from there, the patient was routinely taking simvastatin. They went on to a 10-day course of erythromycin, and we've asked the students, what do you expect might happen? They needed to know that simvastatin is a substrate of CYP3A4, erythromycin is an inhibitor, and so used by about day 10, you've got an increase in the simvastatin plasma levels, leading to increased risk of myalgia, myopathy. Now, they might see the patient in the ED or on the ward complaining of muscle aches and pains that have got worse over the last, 2 weeks. Asking those drug-related, could be a drug cause of this, is something that the consultant or the registrar may not be thinking of. They're just dealing with the presenting symptoms, I should say.
Yep. I love this kind of talk. My PhD was in pharmacology, but I can't remember all of this. Is it reasonable to expect our students to remember all of this, or is there a strategy that goes beyond remembering?
Sure. This is application of knowledge. So it's recognizing that there might be a risk and then using the resources that they have available readily to them. And the three that we focus on for mainstream medicine are the Australian Medicines Handbook, the AMH, the ETG, the Electronic Therapeutic Guidelines, and the approved sponsor product information. There's many other resources for, if the patient was pregnant, or we're wanting to focus on specific interactions, that we might use other resources. But if it's the 80-20 rule, if you've got access to those three, you can answer most of the queries that you need, if you've got that background knowledge to then look and interpret the data in front of you. So AMH is much more about drug brief monographs that gives you an idea of what the common indications, the common precautions, contraindications, the common dose, and some practice points. And you can look at that and know that, famotidine is a H2 antagonist, or if the consultant says, select a PPI, proton pump inhibitor, for this patient, and you think, my goodness, I can remember one from uni, but there must be a bucket full of these. They can go to the AMH, look up PPIs, and will give you over 2 or 3 pages, all of the PPIs and anything that might, based on the other things going on with that patient, their polypharmacy, their comorbidities, their liver, their renal impairment, which might be the better option. So a PPI that's more watery, like pantoprazole, is going to have less interactions than one that's more lipophilic, for example, because there's less liver passage. So the AMH is probably the one that, if I was working in the UK, every doctor has a BNF, the British National Formulary, in their pocket on their phone, and the AMH is the Australian and New Zealand version of the British National Formulary. So that's sort of like a clinician staple, but it doesn't start with the medical condition. The ETG that's set up a bit like the various medical specialties, gastroenterology, endocrinology, etc. It starts with that umbrella and it moves down within, say, gastroenterology to constipation, diarrhea, you name it, endocrinology, thyroid dysfunction, etc. So if you're looking for what is an Australian best practice approach, current probably for the last 3 years. They change and update about every 3 years with a revision. But how do I manage that condition? And if there are 3 or 4 options in the toolbox, think about heart failure. What do I use first, second, third? So it gives you a therapeutic approach. It doesn't give you any useful information on the individual parameters or characteristics of the drug you might choose.
Yep. So they sound like nicely
Yeah,
complementary
yeah.
approaches.
Whereas
So
the product information, just to tie that up, is the legal document owned by the sponsor, and it will only talk about the approved product indications or the approved patient populations that they've sought approval for. It doesn't mean that that drug cannot be used in other settings off-label. So if the students think of it still useful, but it's a legal rather than a clinical document, then you know when and when not to use it.
yep. Okay, thank you. So I want to dig down a little bit about how you go about learning these things, because as sort of intimated, it's different when you're an intern. You might learn, by actually writing. You have to write scripts, and you learn from your practice about that. But there are some restrictions around, some difficulties around that with actually writing scripts.
Yeah.
But there are lots of roles, where a student can, step up and do something. And we discussed one of them was being an advocate for that perhaps a particular symptom is related to a drug, or asking a good question about a drug interaction. What do you suggest that the students doing a medicine term actually do with their time on the ward? The supervisor's gone away, they've got a patient, they've got a drug chart, they've got a ward. How can they use that as an opportunity for learning?
I think it's a really great opportunity for learning, because as they go from bed to bed, the drug chart or charts on the end of that bed, or if it's an electronic prescribing hospital in the PC that they hopefully will have at least viewing access to rather than writing access, they can see a whole lot of things. First of all, the structure of the National Inpatient Medication Chart is very useful. It tells you whether the intention of the prescriber is that this is a regular medicine. In the middle of the chart, it tells you if someone says, right, I want this 3 times a day, that there are 6, 2 and 10 for that, whereas if it's every 8 hours with an antibiotic, it needs to be 8 hours specifically apart over the 24 hours. If the drug written up is, I don't know, metformin, there's a box on the regular medication chart that says SR, controlled release. There's a huge difference in risk between an immediate release and a controlled release dose form. Is it clear which one was intended for this patient? What if they look at the patient's been in for 4 days and there's a whole lot of missing doses, and there's a little key in the middle of the chart that gives a code for why the dose might be missed, for example, nil by mouth, etc. If that's not filled in, go and ask the nurses, why was that dose missed? If there are 2 drugs, IV, that are being given at the same time. They can then look up at the IV bag and the burette beside the patient and have a look and see where was the drug placed, in the main bag, in the burette, in a mini bag, and why. Think about, for example, a patient with sepsis having gentamicin and ampicillin or amoxicillin at the same overlapping time. One given exactly in the burette with the other. One's a large acid, one's a large alkali, and you get a big white precipitate. So that explains why those doses have been spaced apart. So there's so much you can learn, and then have a look at what's been prescribed, compare that with the ETG or the best practice guideline for treating whatever heart failure, and are you seeing in front of you the recommended regimen? And if not, why not? Why is there something about this individual patient that would make that drug choice not suitable? And ask your registrar, the junior doctor you're with, the why. And sometimes they'll be able to answer it, sometimes they won't, but you'll both learn out of the exercise.
Yep. So the conducting some sort of chart reviews where you're looking for the quality of the charts, where you're looking for interactions, where you're looking for the understanding the indications, or the are all good, helpful ways of taking that chart and learning from it. What about talking to the patient? Okay, you've got all that rich information in the chart. How do you leverage off the patient, particularly as you think of the broader aspects of prescribing than just the paper document? You spoke about it as a communication function.
Yeah, exactly. And so this all starts at the point of the patient either presenting to the emergency department or in the communication between the ED and the ward prescribers. So if we take the fact that you're in the ED at the moment, it's usually the junior doctor, and you may be there on placement with them, that's going to take that medication history. And understanding that what may be in the letter that's come from the prescriber, the GP to the hospital, doesn't necessarily mean that's what the patient's actually doing with their medicines. And so taking an accurate medication history makes, and using more than one information source. So one might be the GP letter, but the patient is the other source, and matching up. They'll say, well, I don't take that any longer, or it gives me, makes me dizzy, so I only take it when I'm at home, not when I go out shopping, for example. Do they have some sort of dosing aid? How adherent and how willing to be adherent are they? Because if you don't have an accurate baseline, then you can't make changes once the patient's in the ward. So being open, not being judgmental, and bringing the patient along with you in that conversation means that when you take that medication history, either in the ED or when they present to the surgical ward, pre-admission clinic, or into the medical ward, you've got an accurate picture of where to go next.
One thing I sort of wonder about our students being more involved in is assessing patients' understandings about their medication, say prior to discharge. How would you go about, the being able to assess a patient's understanding of the medication and report back to the ward round that this person's ready for discharge or not?
Okay, so obviously the level of cognition of the patient is important, and whether their home circumstances, are they living alone independently? Is it their wife, for example, that looks after their medication, or are they in an aged care facility where they're much more passive in this process, is an important first step, and understanding of that. And if it's not in the notes, And you need to ask the patient or the person that's sitting beside them in the ward. And then once you know, well, they've got reasonable cognition and they are independent of their meds, like taking their medication, and they've got on board useful aids, like, say, a Webster pack or something that makes it a little bit easier for them, then the next step is working out what do they actually know about their medicines. So there's a number of ways you can do this, but if they're already in the ward, there probably is a chart in front of you or the medicines in the bedside cabinet. And rather than making them remember everything when they may not be feeling too well, pull the chart out, pull their medicines out and put them in front of you and go through them systematically and find out which ones they think are important and what they believe they're taking the medicine for. For example, if it's amitriptyline, you might be going immediately to neuropathic pain, but maybe they're taking it for the indication of incontinence. And is it important for them to be on it or not? And when do they take it? If it's once daily, for example, are they taking it in the morning or are they taking it in the evening? And what's their rationale for doing so? And the reason I mention that is because if we're dealing with, say, incontinence, do we want them to be up in the middle of the night and perhaps have risk of a fall versus when they're a little bit more awake in the daytime? So and then you need to actually document what the patient's perspective is and relay that conversation back to the treating team, because often it's where the patient places importance on a medicine that tells us which ones they will and won't adhere to.
I like that it's a good example of the teaching back method of checking our understanding. We tend to provide a lot of education to patients, but a good way of checking is to ask them to teach us back. And that works for medicines, it works for other things as well. So that gives I think our students a few ideas of some really practical things they can do that improve patient care and make a contribution to the team, as well as being opportunities for learning. So I guess one of the other things I wanted to ask about is I, as an oncologist, think of the oncology pharmacist as being, such my interaction with them being such a core example of teamwork. So our students can learn on their ward placements about, the contribution of the pharmacist and about working as a team. How do you suggest they go about that? What are the key strategies and things that they can do to learn about how to work well with the pharmacist on the ward?
Well, I think the first thing is introduce yourself so that you know who the ward pharmacist or the clinical pharmacist for that area is, and ask them, can they go on a round with the pharmacist? We do that with our UQ students at Mater. The second year grad med 2 do a half day in with the pharmacists on various wards during their 6 or 7, whatever it is, week placement at Mater. And so you actually start to see from a different perspective the implications of a prescription not being clear, not being transparent. And the pharmacist's role is really all about medication safety and optimizing medication use for that individual. So whether it's trying to clarify for the nurse what the doctor has intended but not actually written, or trying to safeguard the patient because there's a risk in what's been prescribed, and resolving those issues so that the dosing for that patient can go on without a gap. So I think walking in the pharmacist's shoes for a day out of their X number of weeks in that rotation can really give them an idea of what they can personally do to improve their practice as junior prescribers. And if you know those safeguards, then you often don't make those errors inadvertently in the future.
I really like that as a suggestion. It's all about relationship, isn't it?
Yeah.
And introducing yourself, expressing an interest, showing your respect for their opinion, spending some time with them. It may be that you've got questions that you want to ask the pharmacist later, or that come up with other patients. On the background of that relationship, you're going to get a completely different response to the trying to ask someone who you've never met before. Yeah, so that's I find that a great approach for learning teamwork in general. Well, we've covered a lot of ground. Thank you, Treasure.
That's all right.
It's an important topic. You've highlighted the really key quality and safety aspects that drive why learning this is important. You've identified some useful resources that people can use to support their learning. And you've identified some practical things that people can do on the ward to learn about side effects, to learn about drug interactions, to learn about how to write a prescription well, and how to work as a team. So there's a wealth, there's some gold in these hills. And I think a lot that our students can take away. Sometimes students think if they don't have somebody talking to them, and spoon feeding them some wisdom, that they're missing out. But I think you've highlighted some ways that in a self-directed way you can go approach a patient, approach a chart, and learn some really valuable stuff. So thank you. Is there anything you want to say in closing?
Maybe just to highlight something that happened very recently. Do you remember last week where Queensland Health, all of the electronic systems for prescribing and every other activity in the hospital went down for a considerable period of time, and there was absolute chaos because people had to go back from an e-world to pen and paper. And I actually had some of my colleagues at Mater say that they're really glad that we are still on pen and paper because it makes people think, and they actually found that some of our students at Gold Coast Hospital were very, very useful because they've been more used to working in a manual rather than an manner to sort of supplement and support some of the prescribers during that very harrowing number of, 6 or 8 hours. So don't think just because it's it's always going to be easier and safer. It's those core concepts of prescribing, whether it's talking to the team and providing a justification for whatever decision making, whether it's writing on a national inpatient medication chart or keying in to a PC, the concepts underpinning medication safety are exactly the same.
Okay, thanks very much.
That's okay.
Well, I hope you found that useful and got some tips for continuing to improve your prescribing as you go through your clinical placements. Check out other videos in this series or other series that we have online. I will put the references that Treasure referred to in the end slide. Good luck.